Hello, my name is John Tsai, and I'm one of the nephrologists here at UC Irvine Medical School. In this video, we will continue our exploration of renal physiology with discussing potassium regulation in the kidneys. As a reminder, this is a part of a series of lectures exploring the different physiological aspects of the kidney. We've already discussed how the kidney handles water and sodium. In this video, we will be talking about potassium regulation, the second most abundant electrolyte in our body. And in the next video, we'll be delving into how our kidneys regulate the acid that is produced in our body. Lastly, we'll wrap up with a video recapping and synthesizing the hormonal aspects of the kidney. I want to first start off by describing the potassium issue in terms of where the potassium is coming from, where it's located, and where it's going. Most of our potassium stores in our body are located in our muscle, bone, liver, and blood cells, basically the intracellular components of our body. We ingest potassium in our diet, but most of this potassium we actually don't need, and we have to get rid of it or it will accumulate in our body and cause problems. The excretion occurs through two main mechanisms, the kidney, of course, and the GI system. About 90% of the potassium is excreted through the kidney, while about 10 to 50% is eliminated through our GI system. Our kidneys are such an integral part of potassium handling that if anything happens to that renal excretion, the potassium levels in our body quickly get out of whack, leading to hyperkalemia, which can potentially be fatal when high enough. And in the setting of kidney disease, our GI system basically has to take over the task of excreting that potassium from our body, and we can utilize medications to help draw that potassium into our gut to have it eliminated. Now we understand the issue that we were dealing with, we can delve into the minute aspects of the kidney that control potassium levels. Let's first talk about where potassium is reabsorbed or secreted in the kidney. Like sodium, potassium is freely filtered through the glomerulus, and most potassium is reabsorbed in the proximal convoluted tubule, as you would expect from what we talked about in the first lecture. The proximal tubule reabsorbs about 65 to 70% of the filtered potassium load via solvent drag when water is reabsorbed. As we progress through the nephron, an additional 20% of the potassium in the filtrate is reabsorbed in the thick ascending limb of the loop of Henle through our friend, the NAK2Cl cotransporter, the same one that is blocked by diuretics. Lastly, the distal tubule is then responsible for either reabsorbing potassium or secreting potassium, depending upon the hormone aldosterone in response to either low or high potassium levels in the body. While our kidneys are inherently designed to reabsorb sodium, regulation of potassium is slightly different in that instead of only controlling how much we have reabsorbed, as in the case of sodium, we have the ability to actually excrete any excess potassium that we don't need. Perhaps it is because small fluctuations in potassium can lead to deleterious consequences for organs, which is not the same when it comes to sodium. Additionally, our other cells in our body have the ability to help regulate intravascular potassium levels in order to help maintain normal potassium levels or normal kalemia, and we will be discussing this later on in this talk as well. For another in-depth review of this, you can visit the Range Physiology website I have listed here as an additional material to review. Now let's delve into the details of how our kidneys deal with low and high potassium states. Remember that prior to the collecting duct, any potassium that we really need has essentially been reabsorbed in the proximal tubule, as well as the ascending limb of the loop of Henle. We are in the collecting duct now that helps fine-tune that potassium levels, whether in excess or in short supply. In low potassium states, our collecting ducts act to reabsorb any remaining potassium that has made its way to this point through the activity of the H plus K plus ATPase. In this situation, aldosterone is also turned off in response to low potassium stores, and we will discuss the importance of aldosterone in the next slide. Again, this is usually a rare situation because we're usually in a state of potassium excess, but these low potassium states can occur, and this is our primary defense mechanism for preventing further urinary potassium losses. Now, what about high potassium states, which is so much more common? I want to first state that you don't have to have an overtly high potassium level to have a high potassium state. What I mean by high potassium state in this situation is an excess of potassium beyond what is necessary for our body to optimally function. In this scenario, we don't want to be reabsorbing potassium, and instead we want to be getting rid of this extra potassium from our body. The action of this is primarily led by the hormone aldosterone. In high potassium states, aldosterone activity is elevated, which leads to activation of the epithelial sodium channel, or ENaC. This is the same ENaC channel that we discussed in sodium regulation. Now, in addition to reabsorbing one sodium molecule, the principal cell has to get rid of a cation in order to maintain electroneutrality, and this is done through the ROM-K channel. Additionally, there's a maxi-K channel that also allows for potassium to be pumped out of the principal cell. The activity of the maxi-K channel is thought to be mediated by angiotensin II, but the magnitude that potassium is regulated through this channel is unclear, with aldosterone-mediated ENaC and ROM-K pathway being likely the more dominant one that you should remember. Because maintaining potassium levels is so important in our body, we have other mechanisms which work to precisely regulate the potassium concentration in our serum for optimal organ functioning. The muscles are the other major player for potassium regulation in our body, aside from our kidney. Through activation of beta-adrenergic receptors as well as insulin, both of these result in higher uptake of potassium through the NAK ATPase activity shown in this figure. The result is lower serum potassium levels until our kidneys are able to eliminate that excess potassium from the body. These 2 points of potassium regulation are very important avenues that we can use to therapeutically reduce a patient's potassium level quickly and effectively in the setting of hyperkalemia. Finally, in the setting of abnormal acid-base disturbances in our body, our cells can help regulate our acid-base status at the expense of potassium. This is seen here in these two diagrams. On the left, hydrogen ions in the setting of acidosis, for whatever reason, results in hydrogen ions shifting into the cells. To maintain electroneutrality, a potassium ion is secreted at the same time. This results in assisting with preventing severe acidotic states in the blood, but this also results in higher potassium levels in the body, or hyperkalemia. Hence, we typically see acidosis and hyperkalemia hand in hand in clinical practice. On the right diagram, we see the opposite happens in alkalotic states. Hydrogen ions are excreted to help maintain our pH balance, but this is at the expense of potassium shifting back into the cells. We also see hypokalemia with alkalosis as well in the clinical setting, but this is usually rare compared to hyperkalemia and the acidosis combination. Now, we can also use this property to help us treat abnormally high potassium levels. If we want to get potassium to shift into cells, we increase the pH of the blood, which will then result in hydrogen ions coming out of the cells, but potassium entering into the cells. We do this by giving patients sodium bicarbonate, which increases the pH of the blood and helps drive potassium into the cells as a byproduct of hydrogen ion shifting to try to neutralize the sodium bicarbonate that is artificially provided to the patient. Now let's summarize what we have learned about potassium regulation by talking about some potassium-sparing diuretics. There are generally two classes of potassium-sparing diuretics that we use. The first are called mineralocorticoid receptor antagonists, or MRAs, and the other are epithelial sodium channel antagonists, or ENaC channel antagonists. Mineralocorticoid receptor antagonists prevent the action of aldosterone from binding to the mineralocorticoid receptor, which prevents the translocation of the epithelial sodium channel to the luminal membrane. Because it prevents ENaC from being active, this results in sodium bypassing the cortical collecting duct, subsequently resulting in a diuretic effect. Remember, where sodium goes, water follows. Similarly, if we directly block the epithelial sodium channel with a medication, the result is the same and can cause sodium molecules to bypass the cortical collecting duct and eventually be wasted. Because of the lack of ENaC and distal sodium delivery, both classes of medications have the side effect of potassium retention, which can lead to high potassium and hyperkalemia. Why use one versus the other? MRAs have other pleiotropic effects around the body that offer potential other effects, while medications that directly block the ENaC channel don't have those other activities aside from the diuretic effect. In fact, MRAs have also been shown to help remodel our kidney after injury and prevent proteinuria. Additionally, they have also been shown to have good effects in heart failure, liver disease, and diabetic kidney disease outcomes, which you will likely learn about more in your pathophysiology courses. Lastly, I'll leave you with a question to test your understanding of the material we have presented so far. Fludrocortisone, or Florinef, is used for the treatment of adrenal insufficiency, a condition where you are not able to produce aldosterone. Knowing that this medication activates the mineralocorticoid receptor similar to aldosterone, What is the expected effect on sodium and potassium regulation in the kidney? Pause the video here to think about this, and continue on to the next slide when you have your answer. The two side effects that we expect are sodium retention and potassium wasting. Fludrocortisone attaches to the MR receptor as well as aldosterone does, and essentially performs the same functions, namely enhancing E-night translocation to the luminal side. This results in sodium retention, which can lead to high blood pressure, and potassium wasting due to the increase in sodium reabsorption with a potassium molecule being excreted through that ROMK channel. Now, you can imagine in which setting this would be helpful. In a patient who is hypotensive and has high potassium levels, when you can't get any other medications to lower potassium levels, such as diuretics, since these will typically make them more hypotensive. Thanks for joining me today on this video on understanding potassium handling in the kidneys and how we also regulate potassium in our blood through shifting into our other cells, especially our muscle cells. Here are some other great resources to solidify your knowledge of renal potassium handling that you can review. And in our next video, we'll be discussing how our kidneys handle acid and maintain a normal pH in our body.